Well, welcome everyone to the latest episode of A Conversation with CHC. I'm Joel White, the Executive Director of the Council for Affordable Health Coverage. And there's been a lot of talk lately about the skyrocketing cost of healthcare versus the quality of the care received. And here in DC, Congress just passed a bill and they've been discussing a lot about how to reform Medicaid. And my sense is they need to look no further than the states and the states that have really taken a lead in taking on some of the costs in Medicaid and how to produce better outcomes for patients. So I'm lucky to be joined today by Billy Millwee. He's been at the forefront of designing and implementing outcomes-based quality programs at the state level. Billy is the former Medicaid director from Texas. He understands at a very granular level, at a real level, the outcomes that are important to patients and to states and to everyone involved in making Medicaid work well for patients. So he's here to talk to us about how we can be smart about saving money and improving outcomes, particularly in Medicaid. Billy, welcome to the discussion.
Glad to be here, Joel.
Yeah, so talk to us a little bit, Billy. You've implemented an outcomes-based quality program in Texas. Can you kind of walk us through what that program entailed?
Sure, glad to. Before I get into the details, let me give some background and context, if you will. Over the last several decades, states, including Texas, have increasingly moved toward managed care, largely to better manage costs in Medicaid spending. And during the early years, the emphasis was around cost certainty or budget predictability, meaning that states could more accurately predict program costs because those costs were calculated on a per member per month rate rather than the unpredictable and unmanageable costs associated with a fee-for-service system. And now today, about 75% of Medicaid members receive services through a risk-based managed care model. But over time, that focus has changed from one of cost certainty and budget predictability to one that emphasizes cost efficiency, quality, and member satisfaction. In Texas, we were fortunate to work with our legislature to put in place a program that is designed to reward managed care plans that are more cost efficient, have better quality, and greater member satisfaction. And that program is known as the value-based default algorithm. And here's how it works. In Medicaid, members can select a managed care plan based on a number of variables that they may want to consider. It's like available networks or other factors. But many members, a lot of them, and it varies by state, but as many as 30% or more do not select a plan. And for those members that do not select a plan, the member is simply defaulted by the state into a managed care plan. And in most states, that default is based on kind of a round robin kind of process where each plan is given a default of some members in a sequential order without regard to the quality of the plan. And so what that means is that these members are really kind of high value to a health plan because they aren't as engaged with the healthcare system and may not use services as much as many other members. What happens then is a member could be defaulted into a plan that actually has higher cost, lower quality, and lower member satisfaction, and they're rewarded then for that lower level performance. Texas, we put into place a default algorithm that rewards those plans that have lower cost, higher quality, and greater member satisfaction. And that algorithm is informed by three domains that are relatively simple to measure and based on existing data. In other words, we didn't have to go out and spend millions of dollars to put this into place. Three factors considered: cost efficiency, quality, and member satisfaction. Cost efficiency is measured by comparing the actuarially projected expected medical loss ratio to the actual medical loss ratio. So if a managed care plan, actual MLR is at or below its projected MLR, then it's considered to be cost efficient. And remember, if you're not steeped in actuarial processes, how managed care rates are set, the MLR is calculated when the rates are established by the actuary. So it's an actuarially measure. Quality, three measures are considered relative to quality. And those measures are preventable emergency department visits, preventable hospital admissions, preventable hospital readmissions. These measures were selected because they emphasize access to primary care. So if a plan has a good primary care network, then people in that plan are less likely to use the emergency room for primary care won't be admitted to the hospital when they don't need to be, and after discharge from a hospital, receive appropriate follow-up care to avoid a readmission. And these measures are risk adjusted. That means that a managed care plan can't argue that, well, my rates are higher because I have a sicker population. Member satisfaction is the third criteria, and that's informed by two variables. First is the member choice rate, the rate at which members select that plan already, meaning that they're highly regarded by the consumer. And the second is an annual consumer assessment of healthcare providers and systems survey. These surveys, every state completes them to measure members' experience with the healthcare system and their managed care plan. So it's data that already exists. So using the default algorithm ensures that when members are defaulting to a plan, that those defaults favor a cost-efficient, high-quality plan with better member satisfaction rates.
So it sounds like you're getting to kind of the holy grail that a lot of people talk about with value-based care, right? Like you're trying to drive down costs and at the same time improve outcomes. Did Texas did you look at how much this program saved?
Well, yes, we do have some data around how much we save, particularly on the quality measures relative to the preventable emergency department visits, hospitalizations, and readmission measures. The cost for preventable emergency department visits declined by 5%. Preventable hospital admission rates declined by almost $550 million. Preventable hospital readmissions reduced costs by another $25 million. So the net savings in the first year on an annual basis, about $80 million. And then what's important though is we're seeing the cost trend go down, and the plans are competing on a cost and quality and member satisfaction basis. So it shifts the competitive basis of the plans to obtain members.
So more competition, lower costs, better outcomes, better customer satisfaction.
Yes, absolutely.
I'm wondering, they say every state is different. You've got really 50 Medicaid programs, not one. What's the burden on the state? Like, is it really hard for a state to adopt this?
It's really not because, like I said, the Texas program was based on existing data that every state collects. So every state collects encounter data from managed care plans, and that encounter data then is used to calculate the quality measures. Every state already does a member satisfaction survey, and every state that has managed care has an actuarial process that measures the medical loss ratio when they're calculated, and also the actual plan performance. So that was kind of the beauty of this approach, is that we didn't have to spend millions of dollars to set up a program or create a new data system or do anything. It's already data that we're capturing.
So one of the things we've been having a discussion on here in Washington is changes to the Medicaid program, really to save money through program reforms that look at enrollment and eligibility and work requirements and things like that. How would this be kind of, if Texas is like a kind of a model here, how would other states adopt this? I assume they could do it on their own. Would they need a waiver, or is this something Congress should take a look at to say, we really ought to be thinking about this nationwide?
Well, the savings in Texas, really, it's not an outlier. Every state could do this, and they wouldn't need a waiver in order to establish this, or really any special permission. They could do it if they chose to do so. A recent study titled 1% Steps for Healthcare Reform. I think we're all looking for that silver bullet that's going to magically save hundreds of billions of dollars in Medicaid. But this 1% study looked at really the model that Texas is using. It's called the Smarter Managed Care Defaults, and found that that alone would translate into almost $10 billion in annual savings. Certainly something that would help the Medicaid program. It's not the silver bullet, but it is one of many things that could be done. Congress could adopt a statutory requirement that could be put in place that requires each state to develop a methodology to inform its managed care default mechanism that considers three variables: cost, efficiency, quality, and member satisfaction, without getting into how they must do it. The requirement, it doesn't pose an inordinate burden on states because, like I said, the information is already collected and derived from existing administrative data. And by placing emphasis on these three variables, cost, quality, and access, there's no accusation that congressional members are forcing Medicaid members into managed care plans that are low quality and low because they're low cost, but rather that Congress is using the requirement as leverage to ensure that members are defaulted into high performing managed care plans that demonstrate value. So yeah, a statutory approach could be taken with a light touch of just saying, hey, this is what we need to do with our managed care plans. Our states could adopt the mechanism if they so chose to do so.
Sounds like a win-win-win, one of those rare birds in the healthcare space.
That's true. That's true.
Well, Billy, thank you for being here and sharing your expertise with us. I think we're going to continue to hear a lot more about outcomes-based programs. This is just the beginning of the conversation. So really appreciate you being here.
You bet. Glad to, Joe.
And as always, if you'd like to learn more about CAHC, just go to chc.net, and I'll see you on the next episode of A Conversation with CAHC. Thanks.